All right. Hello, everyone. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. And today I'm talking about cervicogenic vertigo. None of this is intended as advice, so to speak. I'm just going to talk you through my thoughts and kind of my algorithm on this diagnosis and some of the current literature on this topic. I get a lot of questions about cervicogenic vertigo as I treat a lot of patients who have vestibular issues, who have other central neurological issues that cause them to be dizzy or to have the illusion of vertigo. And this is probably one of my last talks on vertigo before I go on to some other subject. So first of all, let's define vertigo. Vertigo is where we have the illusion of motion. Typically, when a doctor uses the term vertigo, they're referring to spinning rotational vertigo. Although if you feel as though you're rocking or bobbing, moving in that sort of manner, that's also considered vertigo too. So cervicogenic vertigo patients can have the illusion of rotational vertigo, and they can also just feel dizzy. And there's no just in that, but they can also feel dizzy, and that can be part of their condition. And good morning to everyone who's joining. The issue with cervicogenic vertigo, as is the issue with other conditions within the dizziness and vertigo world, is that there's not one objective test that we can say, okay, this means you have cervicogenic vertigo. Basically, once a doctor has ruled out other causes of your vertigo or dizziness, and if you are reporting neck pain, and particularly if you're reporting a recent neck injury, like a whiplash, then cervicogenic vertigo will come into the diagnostic possibility. They've done studies and they've tried to compare individuals with vertigo of cervical origin to vestibular neuritis and also migraines. And in essence, the problem with cervicogenic vertigo is that these symptoms very much overlap with migraine patients. So there are a lot of migraine patients who have dizziness and or vertigo and their neck hurts. And for a doctor to say you are different from that migraine patient is difficult because some migraine patients may not even have head pain. It can be called a migraine equivalent where the neck pain is part of a migraine. So that's the reality behind this diagnostic issue for doctors and patients to a certain degree. What I will say is that it's always best to look at the functionality of your balance system to understand how to impact that, not only for you, but for your doctors. By that, I mean, it's important to understand that your inner ear has great impact on your balance and regulation of not feeling dizzy. Also, your eyes have great impact on that. So your visual information ties in with many areas of your brain to say, this is where I'm at, as does your neck and particularly your feet. Your neck and your feet send tremendous, I should use that word, but you know what I mean. They send a lot of information from your neck and your feet to your brain. In fact, most of your receptor density for muscle stretch is in your neck, because your brain needs to know where all these muscles are when you're rotating your head for you to have a good sense of where you're at relative to your surroundings. So by considering it that way, it may help you, because so often as a doctor, we have to put a diagnostic label on a condition. I was talking to an individual this week about the diagnosis of triple PD, referred to as, I'm not going to go through all the P's, but triple PD, you can look it up. Persistent postural perceptual dizziness, I believe, is the way they're arranged, but I may have had the arrangement a little different. Nonetheless, triple PD has become the diagnosis where if you have had a panic attack and then you're dizzy afterwards, that's triple PD. Whereas if you had a concussion and you're dizzy afterwards, that can be triple PD. And if the dizziness is worse with motion, or if you had vestibular neuritis and you have damage to your vestibular nerve and you're dizzy after, that's triple PD. So the problem with that diagnosis, in my opinion, is that we're lumping way too many things into one diagnostic subset. And so basically, if you're dizzy with motion, then you have triple PD, no matter what the cause is. And There is some of that with cervicogenic vertigo overlapping with migraines. From the patient standpoint, probably the best thing, the two most important things for you to know is that if you have dizziness after a whiplash injury, it may be your neck. And let me hide this. Let me bring in this slide. It may be your neck. Here you see all the joints of the neck, because those joints can be stretched. The capsules can be stretched. There can be a lot of inflammation. The joints aren't moving right. If you've ever had a whiplash, you know what it feels like. It's not fun. And then that disturbs communication from the joints and the muscles up to the brain. Another possibility is that individuals can have vertebral artery syndromes, including the beginning of a vertebral artery stroke or a full-blown stroke after a whiplash. And that can create dizziness and vertigo. So it's very important to differentiate the two, because a vertebral artery stroke can be very, very serious. And we can diagnose that with certain types of imaging like MRAs, magnetic resonance angiography, or CT angiography, to look at those blood vessels to make sure there's not a clot there. That's really, really important. And if I see a patient who's having persistent dizziness after a whiplash injury, and they're having some other neurological symptoms, like particularly nausea or vomiting, or they're seeing double, or one side of their face is numb, those are big red flags that that person needs some imaging or an emergent ER referral. So that's number one. So kind of having the awareness of, could this be my vertebral artery, or is this related to the damage to my neck? And then two, let's say if all the other main significant issues like vertebral artery pathology is ruled out, then having a treatment geared at the neck, like physical therapy or chiropractic adjustments, if deemed to be safe. Again, this is not medical advice, but I'm just saying these are the thoughts that I work through. Then some sort of manipulative or physiotherapy or chiropractic procedure aimed at the neck can then maybe help this individual. And this is where you will see or talk to physical therapists who say, I've worked with dizziness and vertigo patients and I get great results. Or you talk to a chiropractor and they say, gosh, I have great success treating vertigo through my adjustments. And they're likely right. And the reason why they're right is because the neck has tremendous input into the brain. And so there are multiple ways to skin a cat. And if someone has had an injury to their neck and then they're dizzy, and then you have treatment to the neck and your dizziness goes away, that pretty well confirms cervicogenic vertigo. But let's say you didn't have an injury to your neck recently. Let's say you have arthritis in your neck, and now you're seeing a physical therapist or a chiropractor. They're working on your neck, and all of a sudden now your dizziness is better. Well, I would still surmise that was in part possibly a cervicogenic vertigo case. They may have had migraines too, because you can work on the neck, and there's a lot of discussion in the manipulative therapy world about working on the neck, and some migraine patients getting better. That's why in my opinion, they came across the use of Botox. They inject Botox into forehead muscles and neck muscles, basically paralyzes them so that the muscle spasm isn't sending the weird signals to the brain. So, in essence, take home points, the neck muscles have receptors that send signals to your head about the orientation of the brain. When it's injured, the accuracy of that communication is impaired. These symptoms can be similar to benign paroxysmal positional vertigo, Meniere's disease, neuritis, and other inner ear disorders. The medical model is pretty much going to be geared towards physical therapy, postural retraining, muscle relaxers, analgesics, and the functional model. That's what I try to hammer home. Oh, where did it go? Stream. Functional model, we try to look at this individual as a whole. Yes, acknowledge the diagnosis, but then deeper than the diagnosis, whether it's triple PD or cervicogenic vertigo or migraines, what are the underlying pathways within the balance and vestibular and somatosensory system that may be abnormal and that we can use to get rid of this person's symptoms? It's kind of more of a MacGyver approach rather than just a cookbook. You have cervicogenic vertigo, so you do this. It's rather looking at, okay, well, this individual has these persistent symptoms. Most of the time that's the case when people are coming to me. And as a result, okay, do I turn their head and then all of a sudden their eyes move differently than if their head is in a neutral position? So that's called video nystagmography. We quantify how the eyes move because they tell us a great deal about brain function, inner ear function. And we can actually do some of these tests with the neck in different positions, which is really cool. And by having the neck in different positions, we may be loading the inner ear in a different way, but we may also be loading the neck in a different way. So then we can hopefully, our aim in functional neurology is to come up with a more precise rehab strategy for this individual than just taking you through cookbook, exercises, looking at your thumb, stepping over lines on the carpet, turn your head while you walk. Those are all good things. And I have friends in the physical therapy world, they're great. But our opinion in functional neurology is trying to be a little bit more specific to the individual. So hopefully this helps you. Again, kind of the take-home point is that if you have had a neck injury and you're having dizziness, very important to talk to a doctor about vertebral artery syndromes. Once a doctor has ruled out everything sinister or more potentially impacting long-term neurological health, then treatments aimed at the cervical spine may help, not only the pain, but may help the dizziness. If you still have residual symptoms, I would consider looking at someone who uses the functional model. I would also consider other potential diagnoses like a migraine equivalent. And I think that pretty well summarizes it. So let me know if you have any questions. Thank you everyone for joining and have a lovely Friday.